emergency message. 86-year-old female came to ER with complaints of generalized fatigue, decreased appetite, and irrelevant talk for the past 3 days. Initial 10-second assessment, airway is patent with no gargling of secretions, stridor or snorting. Breathing, respiratory rate of 20 per minute, saturation of 98%, bilateral air entry present, circulation, heart rate of 74 per minute, BP of 130/70, bilateral S1 S2 heard with no added sound. Disability, GCS of E4, D4, M6, and GR exposure GRPS of 181, and temperature of FW. Adjoint to primary survey, we did a CPC CRP point of care showing total counts of 8, HB of 11.2, platelet of 202, and a CRP of 6.1. ECG doesn't show any significant STT changes, and BPG of potassium of 7.38, bicarb of 22, PCO2 with 32, and sodium of 112. History, sample history, 86-year-old female, non-case of diabetes, hypertension, on medication, came to ER with complaints of generalized tiredness, decreased appetite, and bystander also noticed irrelevant talks, occasional, for the past 3 days. For 3 days back, patient had a history of loose stools, which was relieved on medication. No history of fever, dysuria, vomiting, seizures, chest pain, abdominal distension, or any trauma, or sleep apnea or any trauma. No non-allergic allergies. Medical history, diabetes and hypertension on metformin and losartan. And last meal was today morning, decreased appetite, but she had some juice. On examination, general examination, no pallor, icterus, clubbing, cyanosis, or bilateral pedal edema. Serious S1 S2 heard, respiratory system, bilateral air entry present, CNS, no focal neurological deficit, and parabdomen soft and non tender. Since patient's sodium is 112, we send sodium workup such as urine osmolality, serum osmolality, urine sodium, and serum sodium to lab. And lab shows sodium of 113 with blood osmolality of 230, urine osmolality of 274, and urine sodium of 10. Since patient is having decreased osmolality and sodiumness, it's more commonly a case of hypovolemic hyponatremia. Mostly.
How do you assess hyponatremia? You are claiming hypovolemic hyponatremia. How do you assess hypovolemia?
So, is hypovolemic since patient have a loose stools episode.
Okay. One is loose stools, that is correct. You have a patient who is losing water from the body. Okay.
Then also decreased intake is also.
Patient is not taking adequate intake, both salt and water. Okay, that is also possible. Then dryness of tongue, that you have to check. Then
signs of dehydration, sunken eyelids, mucosal dryness, and inner ultrasound IVC
complete collapse, skin bladder, then urea will be increased, maybe increased, urine output will be reduced. Then you can suspect hypovolemia. Hyponatremia you have already diagnosed. Okay, you have to see whether it is a normovolemic patient, hypovolemic patient, or hypervolemic. You are telling hypovolemic hyponatremia. And is this hyponatremia producing any CNS dysfunction?
Yes, the patient with a history of irrelevant talks,
okay.
And bystander also noticed forgetfulness in that in patient for the past 3 days history. Since it's past 3 days, more than 48 hours, we have to take it as a chronic hyponatremia with CNS complication.
So you are telling chronic hyponatremia. Just now you told that diarrhea is produced hyponatremia. Now you are telling
diarrhea 3 days back, sir. For switch patient.
It is not chronic. It is actual problem. Okay. What is the importance of all these things you are telling us? Chronic and acute. What is the difference in treatment?
acute cases, we have to aggressively treat the patient.
Acute aggressively treat, chronic.
Chronic,
We take little more time because how it has produced hyponatremia, like that only you have to go back. Okay. So if you correct a chronic hyponatremia in a faster way, there is a high chance of spontaneous myocarditis. So better to avoid that and then slowly correct it. Nothing hurry here because there is no seizure, there is no very very low GCS. It's only a mild drop in GCS.
So hyponatremia, we can hyponatremia if any sodium level less than 135, we can classify it as hyponatremia. Basically, depending on the osmolarity, hyponatremia can be divided into hypertonic, isotonic, or hypotonic. Hypertonic hypertonic hyponatremia is mostly due to other electrolytes in
Hyperosmolar. You're confusing.
Hyperosmolar.
It is hyperosmolar or hypoosmolar. Osmolarity depends on your sodium. If sodium is low, normally you get a hypoosmolar hyponatremia. It is like that. When the sodium is low, what will happen? Osmolarity. When the sodium is high, you get hyperosmolarity. But here there are some other material which increases osmolarity, like glucose, mannitol. All these things can also increase hyperosmolarity. When the osmolarity is very high, normally sodium will go down. Okay, but that is not a true hyponatremia. It's a false hyponatremia. But when the hyponatremia actually occurs, it is a true hyponatremia. Osmolarity also increases. So that's why we are checking the osmolarity. Suppose a patient with DKA, his sodium is 120, but sugars are 800. It's a hyperosmolar hyponatremia. There the osmolarity will be high. There is no requirement of treatment. You just treat the sugar. When it comes down, the sodium will increase. It's like adding sugar water, like salt water, we are adding sugar water. If we add more sugar water, what will happen? Salt will come down. But actually salt is there. But if you remove that sugar water, again the salt will come out. Okay.
So here osmolarity will be more than 290, and treatment is treat the cause of.
You know that patient is having diarrhea, loss of water with salt is there. How do you treat this patient? Treatment of diarrhea has to be given.
Has to be given. Then since it's more than 48 hours with only mild symptoms, mild neurological symptoms, we can correct the. We have to first replenish the patient with fluids, and then
fluid with salt.
With salt.
Fluid with salt. What is fluid with salt?
Fluid like normal IV fluid.
Suppose this patient's sugar is very low, 35, because he is not taking. You have hyponatremia. You have hypovolemia. There is a common scenario. What do you treat?
First treat the sugars.
That is the first thing. So we have to give sugar. But you have to also treat the sodium correction. You have to also correct the water correction. So
first give sugars, treat hypoglycemia then fluids.
What fluid you select? You told first give sugar. That IV dextrose you can give. What is the next step? DNS. DNS is the answer. So depending on scenario, it is not given in books. Somebody is having hypovolemia, hyponatremia, low sugars. These are a common problem in elderly. So immediately you have to treat the sugar because sugar is very like if it is low for some 3-4 minutes, it can produce permanent damage. Sodium will not produce such damage. If you correct it fast, then only it will create problem. So give sugar, correct the hypoglycemia, then start DNS. That contains dextrose, that contains sodium, that contains water. Okay. If the sugar is already corrected and patient is fully conscious, you can go for NS also. Okay. Normal saline will be the best option in this type what you have explained, that type of cases.
Then you can also add on
how much sodium it contains? Normal saline 0.1 gram.
154. 154 milligrams.
It is 0.9 milligrams. 0.9 means how much?
9 grams.
17. One is 17 milligrams. 0.1. 1 gram is 1 liter is how much? You have to calculate and tell me. 0.9%.
9 grams. 9 grams.
In
1 liter.
1 liter. 1 liter. We are giving only 500.
So 4.5 grams.
1.5 grams. Each gram of sodium contains 17.1 milliequivalent. So like that we have to calculate and give. We know that it contains some amount of sodium, okay, but not like your 3% saline.
We can calculate. In a minimal neurological symptom, we can calculate sodium requirement, and according to sodium requirement, we can.
How do you calculate sodium requirement?
Sodium requirement, desired sodium. That
Desired
is
sodium means most of the conditions we select it as a desired sodium maybe.
10 more than.
So desired sodium means suppose it is 121, we want to correct only 128. That is the maximum thing we correct. Okay, 8 to 12 is allowed. So we suppose we correct 8. So there is no need of calculation. 8 is desired sodium minus current sodium is 8. Okay. Then into
0.6 into body weight.
0.6 is 60% of the body is water. That's right. 0.6 into body weight. And that will give you the answer. Suppose it is 500 milliequivalents of sodium. How do you
In 3% NS 3% NS contain 513 milliequivalents of sodium.
51 milliequivalents in 100 ml.
100. So, if it is 500 divided by 513, we'll get
10 bottles.
That liters we'll get.
Okay, 10 bottles. 1 liter. 1 liter. That should be given over 24 hours. So divide it by 24. That will give you the infusion rate in hours. Okay. That will be very difficult, but you have to do according to that. Then there will not be any problem. If you don't know all these things, start 10 ml per hour, 10 to 15 ml per hour in hyponatremia. In chronic hyponatremia, it will go a little slower, 10 ml per hour. Every 6 hours, you check the sodium. It should not cross more than 8 milliequivalents in a single correction, in a single day. So next, if suppose it is already corrected from 121 to 128 by evening, you stop that infusion, next day you check it. Don't continue the infusion. So if you do fast correction, what will happen? Osmotic demyelination syndrome. What are the 2 types of osmotic demyelination syndromes? Central and extra bond. Fontaine and extra bond. Okay. This previously it was called as fontaine minor. Now we know that it is
Extra
bonding also there. How do you differentiate these two? Fontaine means what?
Bonds will be more involved.
So what is
So,
fontaine will be like something like a locked-in syndrome. Locked-in syndrome. Extra fontaine means patient have altered behavior, seizure and all. Okay.
If
Can slow correction produce fontaine demyelination syndrome or this extra fontaine demyelination syndrome?
rapid correction more than 12
Rapid. Normally, what we learn is rapid correction can produce all these things, but even slow correction also sometimes can lead to this central demyelination syndrome. Okay, but it is not very common. You can correct it. Rarely it happens. Rapid correction always produces this type of problem.
So it's once it's settled, it's a permanent damage.
Okay, it's a permanent damage. We have to be very careful. So demyelination in CNS and demyelination in the peripheral nerves, what is the difference? Demyelination in the brain or brain cells and demyelination in the peripheral nerves. GP syndrome is in the peripheral nerves are involved. What is the difference?
Weakness with motor. Ascending paralysis.
Peripheral neurons can grow. Central neurons cannot grow. That is the main problem. So centrally, if something happens, that will not grow. It will become a permanent damage. It is a peripheral demyelination like GP syndrome on your patient has got a chance for recovery.
In mild cases, like severe moderate mild 3 times divided into 3 symptoms. Severe, we have to rapidly correct the patient. Most probably, patient will be presented with hyponatremic seizures or coma. So we have to correct 5 milliequivalents. Up to 5 milliequivalents should be corrected. Then mild, we can just give added salts.
Okay.
Like 1 gram of salt equals 17 milliequivalents of sodium. So 1 teaspoon having 17 or 18 grams. So we can give it as capsule form and.
Meaning, what is the normal salt intake in a day for us?
Not for us is 60 to our
60.
diet contains 6 to 8 milliequivalents, but at least 2 to 3
grams.
grams. At least 2 to 3 grams we
Add. For that you have to put it in capsules and give it to the patient. So it is really difficult to take raw salt like that.
So then mind to add if patient moderate, depending on the neurological status added sugar plus 3%
Added salt.
sorry.
We told added sugar.
Yes, added salt.
We like more salt than sugar. Sugar than salt. That is the reason. That's why every time comes as sugar.
Added salt plus 3% MS and severe moderate. Then in a condition SIDH, we are
SIDH actually, what is SIDH?
in the
So what is happening to the water? What is happening to the salt?
So in SIDH, antidiuretic hormone will secrete in inappropriate amount, excess amount. So water will be retained. So sodium will be washed. So
But there is no edema.
no,
You are telling water is retained, but there is no edema. Is
intravascular.
it contradictory? So you have to find out what is the reason for fluid accumulation, not having fluid accumulation in SIADH. There is a reason. Okay, there is a hormone, counter-regulatory hormone that will be produced. So in syndrome of SIADH, antidiuretic hormone, inappropriate production, normally we expect more water is retained. Patient should have edema, but that is not there. Why that is not there? And water is still high. That's why salt is reduced and salt is also removed from the body. Okay, so you have to only find out why patient is not having edema in SIADH. What is the counter-regulatory mechanism which prevents edema in SIADH? You know? So there is a counter-regulatory AMP secretion that prevents extra accumulation of fluid, but still the patient is having more fluid.
Sorry, the treatment is fluid restriction along with added salt or 3% neurological residue. If this is failed, we can start on Vaptans.
Vaptans. What are the two Vaptans? And Conivaptan. Tolvaptan is tablet, Conivaptan is injection. Okay. What is the dose of Tolvaptan?
15 milligram OD.
Or BD you can give depending on the case. And what is the side effect you have to monitor? Liver function test you have to monitor. Where else Tolvaptan can be used? Which other condition Tolvaptan can be used? Heart failure. It's a trial drug now in heart failure because it is this action is same as Lasix. It removes water, but Lasix also removes some amount of sodium. And this removes only water. Sodium will be retained. Okay. That's why it is in trial in cardiac failure. Promising findings are there, but it has not come in any of the guidelines. In cardiac, in dilutional hyponatremia, how do you treat?
Dilutional hyponatremia is hypervolemic hyponatremia, which is mostly seen in cardiac failure, cirrhosis, heart
Liver failure, kidney failure, cardiac failure.
Treatment is water restriction.
Water restriction and Lasix.
Lasix.
Lasix can be given. Okay. What is depletional hyponatremia?
Depletion hyponatremia, patient will be drinking water, but salt intake will be
Where will you get
more,
that?
more in either psychogenic body
Who will have
marathon.
Summer.
Volumeless.
Most of the time it is due to
Pumps.
the advice of the doctor. Advice of the doctor. Because in hypertensive patient, what is the normal advice given by the doctor?
Salt.
Don't take salt. The patient will immediately stop taking salt, especially in elderly individuals. You can get many patients. They, after diagnosing of hypertension, they don't take salt at all. They think that salt can increase the BP. Because we are only advising to restrict the salt. It is not nil salt. They have to take salt. Can salt intake increase the BP? So So if you are taking normal salt, it will never increase. If you are taking extra salt along with your diet, it can increase the BP. Okay, no, all the BPs are not salt responsive. Some BPs are they have response to salt and they increases the BP. Some BP is not responding to salt, means that even if you take large amount of salt, it will not increase the BP. How salt increases the BP? What is the action of salt? If you take salt, more water retention, it produces more water retention, more volume, more pressure. Okay, that's all. Yeah, you have to advise the patient not to take extra salt if they are diagnosed with hypertension. Not to completely restrict the salt. If you completely restrict the salt or if the patient does not understand what you are telling, most of these patients are admitted in ICU are like that. They don't take salt after making a diagnosis of hypertension. They immediately stop the salt. Okay. What is potassium chloride? Red salt. Red salt is potassium salt. Potassium salt, what is that value? Malayalam, it is like the name is Indupur. Sodium chloride, potassium chloride. What is the advantage of potassium chloride? Taste is almost same, but it is not. Potassium is good for hypertension. So hypertension control is better with high potassium. If the patient is not having renal failure, we can mix red salt with normal salt, maybe sodium chloride with potassium chloride, so that the sodium will not be taken as an excess. Additional salt can be this potassium chloride. Himalayan red salt, what is it? Himalayan pink salt. Potassium chloride. So that can be tried. What else? Anything else you want to add? Nothing else. Okay. Thank you.